Get started. We'll see if anybody else is going to join, but thanks to those who did. Hello to everybody. I am Carrie Dicken. Thank you for joining me tonight. I am a reproductive endocrinologist, also known as a fertility doctor. I am at RMA New York in the Long Island office, in the Melville office specifically. As a reproductive endocrinologist, it essentially means I am double board certified. I am an OBGYN, but I am subspecialized and trained in reproductive endocrinology and infertility services. So, now that we're towards the end of June and celebrating Pride Month, I just really wanted to be able to find some time to talk about how a fertility doctor can assist the LGBTQ plus community in having children and creating a family and extending their family and things that we can offer. So feel free throughout the talk, submit any questions you may have. I will address everything at the end of the talk, okay? All right, so I want to start off just by talking a little bit about access to fertility care. And we know that despite significant and really important strides that have been made to recognize disparities in care for the LGBTQ plus community, still individuals face challenges in accessing equitable care as it relates to fertility and family building. We know that many LGBTQ plus and gender non-conforming individuals have children or plan to have children. The data, at least recent data, is kind of limited, but in a study back in 2012, it was reported that over a third of lesbian, gay, bisexual, and transgender self-identified individuals were already raising children. Another study that's out there gives us information showing that about 50% of female individuals in the United States of reproductive age want children, and this does not differ between heterosexuals and LGBTQ plus individuals. So despite all of this, and knowing how necessary fertility treatment is for the community, there's a lot of inequalities in obtaining information and in getting access to fertility care. So really my hope in tonight's talk is that I can shed some light on treatment options that are available. So family building for individuals in the LGBTQ plus community typically requires assistance from a variety of fertility treatment modalities. It's currently estimated that LGBTQ plus individuals make up about 5 to 10% of our fertility clinic patients. And so that tells us that there certainly are barriers to them getting the care that they need. It could be just, it's not brought up as often with gynecologist visits or with primary care physicians, and so there are less frequent referrals. And then, sadly, we know that there's still some difficulty with healthcare insurance and perhaps even meeting traditional definitions of infertility to obtain coverage. So we want to make more strides in that area. Now, there are many options for the community for how to achieve a family. Traditionally, LGBTQ plus community was restricted to foster care, adoption, co-parenting. However, with IUI treatment and the advances in IVF technology, those who identify as LGBTQ plus are able to now have biological children of their own. Fertility treatment options for this community, though, are going to involve third-party reproduction. So what that means is that someone else other than the individuals who are planning to be parents to the future child are going to need, there's going to be somebody else involved in creating that pregnancy, whether that be somebody donating an egg, donating sperm, a gestational carrier. There needs to be a third party involved. And so consequently, FDA regulations of these third parties affect treatment that the LGBTQ plus community needs much more so than heterosexual couples. In going through this list that I have here on the slide, kind of going from, I would say, least invasive to maybe more invasive. Number one, there are at-home options, at-home insemination with donor sperm. In a fertility office, we consider IUI and IVF to be our basic types of fertility treatment. So IUI is an intrauterine insemination. It can be done with donor sperm. IVF traditionally is done using eggs outside of the body, fertilizing them with sperm, which can be donor sperm, and then placing a healthy embryo back in the uterus. Co-IVF, or sometimes called reciprocal IVF, can also be done where both parties can be involved in biologically having this child, meaning we use the eggs from one partner, create the embryos in the laboratory with donor sperm, and the embryo can then be transferred into another partner. So that's a really nice option for some lesbian couples. Donor egg IVF with a gestational carrier is typically what we're going to consider for gay male couples, in which egg needs to come from a donor and we need the uterus to carry the pregnancy. And then, of course, adoption is always an option if, going through these fertility treatments is not necessarily what a couple or an individual wants to do. So let's talk a little bit about donor sperm. When considering donor sperm, the intended parents have the option of using either a known or an anonymous sperm donor. And really, this is just a personal decision. Regardless of the type of donor that's used, various considerations and requirements apply, and the sperm must be meticulously screened by an accredited sperm bank. Okay, so in using donor sperm, a lot of this gets done ahead of time, and it can be a little bit easier. So essentially, when couples or an individual uses anonymous donor sperm, the intended parents obtain frozen sperm samples from a licensed sperm bank, and this sperm already meets all standard criteria set forth by the US FDA. Your doctor will ensure that the selected sperm is medically a good match. There are specific things that we're going to be looking for based on prior testing. But essentially, the patients, the intended parents, are responsible for choosing a sperm donor based on their personal preferences, and then paying the sperm bank for both the sperm and the shipping to make sure that all of the arrangements are made to get the sperm to their treating physician before treatment cycles begin. And one of the major benefits of using anonymous donor sperm is that it's typically available for immediate purchase and shipment. So there really is not any anticipated delay in using anonymous donor sperm. Directed donor sperm, or using sperm from a known donor, is something that some couples or some individuals like to do, asking either a friend or a family member. But as you can imagine, this option brings many sensitive issues and questions into play. And so there are several additional steps necessary in choosing this option. At RMA, we recommend that both parties, meaning the intended parents and the donors, have at least one session of counseling, either with a family therapist or a psychologist, just to discuss issues that can arise and make sure that all the questions that could potentially come up have been answered and everybody is comfortable. There need to be legal agreements and contracts in place, and so both the donor and the intended parents should have separate legal advice and counseling and representation, and they need to be seeing a reproductive lawyer to create valid and notarized legal contracts, both for the safety of the parents and the donor. And then there are specific FDA rules for sperm donation. So according to these rules by the FDA, all sperm donors need to complete a full medical exam, and their sperm must be screened and tested for infectious diseases. And so this includes known donors. So after all of this is done, the physical exam, the initial blood work for infectious disease screening, the sperm then needs to be quarantined for 6 months, meaning it's frozen, stored away, but nobody has access to it. After that 6-month quarantine, the donor is then retested for the same infectious diseases to make sure it's still negative, meaning there couldn't have been something that was contracted and we wouldn't have detected it earlier. And then the sperm, once he's tested again, comes back negative, then that sperm is available to be used for either insemination or IVF. So if you're thinking of using a known donor, it's basically it's a minimum of a 6-month process before the sperm can actually be used. Okay, now egg donation. So gay male couples and LGBTQ plus men or individuals or couples that cannot provide eggs will need to use eggs from an egg donor in order to conceive. And traditionally, this was done by having an egg donor undergo the ovarian stimulation, so using the fertility medications to get eggs to grow, retrieving those eggs from the ovaries and fertilizing them with the intended parent's sperm in the laboratory to create embryos. However, since the technology for egg freezing has improved so much over the past few years, there are now egg banks that exist just like sperm banks. And so I would say more often than not, individuals or couples are choosing to purchase eggs that have already been extracted from the ovaries of young women and are available for purchase, and then they just need to be thawed and fertilized. And so it can make it a little bit of a faster process and maybe a slightly less expensive process that way. The intended parents with this type of situation can also choose to ask a friend or a family member to be an egg donor, meaning like a known egg donor, just like we were discussing known sperm donors. I will say I don't see this quite as often. It brings up a lot of the same issues as using sperm donors. And so I would say nowadays it is just much more common that couples are purchasing eggs that have already been frozen. But whether an embryo is created from a fresh egg with a known or an anonymous donor or with frozen eggs, the embryo that's created then for couples where there's no uterus between the two couples needs to be transferred into a gestational carrier for that gestational carrier to carry the pregnancy and deliver the baby. Okay, so what should you expect if you go to visit a fertility doctor? Before we decide on any kind of treatment plan, we're going to talk to you, get to know you. We're going to take a thorough history. We're going to make sure we understand if there's any underlying gynecologic conditions, medical conditions, family history, and equally as important, we're going to talk to you about your family plans because that's going to help us to figure out the best treatment choice for you. On this slide, there's a list of several different areas that we test. This is more of the objective testing that we're doing. So we're going to do testing on ovaries to make sure that ovulation takes place naturally. We're going to test and make sure that egg quantity seems appropriate for age. We're going to test to make sure tubes are patent. We're going to test uterine cavity and make sure physically nothing's in the uterus. Endometriosis is a gynecologic condition that can affect fertility, and so we're constantly thinking about that. And then, of course, we're going to test sperm, all of this, where applicable, to make sure that within an ejaculate there is a normal amount of healthy, motile, normally shaped sperm. And so we take an individual or couple's history, their family plans, and this objective testing, and we try to figure out the best treatment plan for them to have a child. So when it comes to fertility treatment, the two broad categories of what any fertility doctor can offer is IUI and IVF. IUI is an intrauterine insemination. IVF is in vitro fertilization. For lesbian couples and egg-producing individuals, Donor sperm can be used with either IUI or IVF treatment, but for gay male couples or individuals where they don't have the ability to produce their own eggs, IVF with donated eggs is necessary, and so IUI is not an option for them. IUI and IVF are very different treatment options, both in how they're performed and their likelihood of resulting in a successful pregnancy. So in the next couple of slides, I'm going to go through each in a bit more detail. So we're going to start with IUI. Stands for an intrauterine insemination. Some people call it, or used to call it, artificial insemination. So IUI treatment is often the primary method of conception that we would choose for a young individual who has no traditional fertility challenges. But technically, IUI treatment would be an option for any individual who has ovaries, has at least one patent, but preferably 2 patent fallopian tubes, and has a functioning uterus and is planning to use donor sperm. With IUI treatment, the donor sperm is thawed and washed, which allows us to really concentrate the high quality sperm into a very small volume, and then that gets placed inside the uterine cavity around the time of ovulation. With IUI treatment, the patient has the option of choosing either a natural cycle without medication, meaning that individual would grow an egg and ovulate as they naturally would in a menstrual cycle, or they can choose to use a medicated cycle in which fertility medications, typically oral medications, are going to be used to induce or augment ovulation. I typically recommend using these oral medications. They're called Clomid or Letrozole, right? Those are the 2 options we have. I recommend using them with IUI treatment when my patient is using donor sperm, because donor sperm is expensive, and we need to use a full vial of donor sperm for one insemination, meaning, if you're doing a natural cycle, you're releasing 1 egg, that means you're using an entire vial of sperm just to get that 1 egg exposed to sperm. And I think that using Clomid or Letrozole in hopes of getting 2, maybe 3 eggs will give my patients a slightly better chance and hopefully not cost them more money by doing cycle after cycle. Now, timing the insemination or the IUI with ovulation is critical. So with this type of treatment, we are going to require monitoring. We do it early in the morning. It's typically a vaginal sonogram and a blood draw for hormone levels, and that allows us either to detect natural LH surge, or it allows us to figure out when to provide or instruct someone to use a medication that will mimic an LH surge, and that helps us to time the IUI. The IUI is typically performed 24 to 48 hours after an LH surge. It is really a quick and simple procedure for most. There is no sedation necessary. It's done in one of our examination rooms, and afterwards, patient can go back right away to their normal daily activities. So success rates with IUI. I will tell you that the numbers on this slide, on the screen, really pertain to couples with traditional definitions of infertility who have been trying naturally, have not been able to, and then utilize IUI treatment to get pregnant. So for members of the LGBTQ plus community that are just getting exposed to sperm for the first time with an insemination, their numbers should be a bit higher. But to be honest, it's not significantly higher. And I think that most of my patients are always pretty surprised to learn that this treatment does not give such high odds of success. In general, the fecundity rate, meaning the likelihood of any individual getting pregnant naturally in a menstrual cycle, is about 25%. So doing an insemination is getting someone exposed to sperm, maybe slightly higher chances because you get exposed to more sperm and maybe there's more than 1 egg. But I would say for young individuals going through IUI, where we expect good egg quality, chances of success are probably about 25%, maybe 30% at best. And I think that that's a key point, is that age is really important, even for members in the community that maybe haven't been trying traditionally to get pregnant, age is still affecting the quality of eggs and is going to affect the likelihood of success with treatment. So age is really the best predictor of the chance of pregnancy. And as eggs get older, the chance for healthy pregnancies decline. And so again, when we're taking in the history and figuring out the best course of treatment, age is going to certainly play into our decisions. In general, I believe that most individuals using this treatment, if they're going to be successful, will probably be successful in the first like 3 or 4 attempts at insemination. So after 3 or 4 cycles, I'd like to at least sit down with my patients and start talking about IVF, because I don't want to spend too much time with a treatment that's not working. So IVF, or in vitro fertilization, is the fertility treatment that we have that gives significantly higher success rates. And IVF is quite different from IUI. So with IVF, we stimulate the eggs in the ovaries to grow using injectable medications. The goal with IVF is to have many eggs grow. So with IUI, we were saying even with the oral medications, maybe we get 2 or 3 eggs to grow, but with IVF, ideally I'm looking for 10 or 15 eggs to grow. The eggs that grow can be removed from the ovaries so that we can fertilize them outside of the body. So that gets done in the IVF lab to create embryos. Now, with traditional IVF, the patient whose eggs are being retrieved is going to go through the injectable medication, have the egg retrieval procedure done, and then the embryos created from that person's eggs, we would choose the best 1, possibly 2, depending on the age of where the eggs came from, and put those embryos back in the uterus of the person whose eggs that we got. That is traditional IVF. Reciprocal IVF, or some people call it co-IVF, is a really, really nice option for couples in which both partners have ovaries and a functional uterus. And with this type of IVF, it allows both partners to be involved in the conception of the baby. In reciprocal IVF, the eggs from one partner are retrieved, right? So one partner is going to go through the injections and medications to get eggs to grow. We're going to retrieve those eggs, fertilize them in the laboratory with donor sperm, but the resulting embryo or embryos are then transferred into the other partner's uterus, who can then carry the pregnancy and give birth to the baby. So this treatment makes it possible for one partner to essentially be the genetic parent and the other to carry the pregnancy and give birth to the child. Okay, this slide is just reviewing the steps of IVF. So just to kind of go through it again, first we stimulate the ovaries. So that requires frequent monitoring in the office. Patients come in early in the morning, sonogram, blood work. We're using injectable medications to get these eggs to grow. And then the frequent monitoring is important so we can determine the optimal time to set up the procedure where we're going to extract the eggs from the ovaries. And that procedure is called an egg retrieval. It is done by a fertility doctor. It's done by one of the physicians. It's done with some sedation in the office. So it's not a surgery. It's not done in a hospital setting typically, but it is done with some sedation so that there is no pain. It is all done vaginally, so there are no incisions on the body. The eggs that get retrieved from the ovaries are then evaluated in the laboratory to determine which are ready to be fertilized. And then there can be different ways to fertilize eggs, but most often, especially with donor sperm that has been frozen, we're going to want to do ICSI. ICSI, it's an acronym, ICSI. It stands for an intracytoplasmic sperm injection. It's a very fancy way of saying we are going to select one single normal appearing sperm and inject one into each mature egg that we got at the retrieval. Okay, so once the egg fertilizes, it's then called an embryo, and the embryos that get created need to grow and develop in the laboratory, and that can take 5 or 6 days. And then depending on what the plan is for what to do with those embryos, one choice could be, to choose the best appearing embryo, just subjectively put it in the uterus in hopes of achieving pregnancy. Another option is to biopsy each embryo that appears to have developed normally. This biopsy, a biopsy means removing a couple of cells from the periphery of the embryo. This biopsy can then be sent out to a specialized lab that can amplify the DNA and actually screen to determine if there are a normal number of chromosomes in that particular embryo. And this is something called pre-implantation genetic testing. I'm going to touch upon that a little bit more later, but this will by far give most couples or individuals using IVF their best odds of success. Okay, so the question that everybody always wants to know is IVF going to work? And I would say, with the evolution and progression of our IVF technology, the success rates have significantly risen over the past 3 to 4 decades. And you can see on the graph on the left how clear that is over the years. But it's important to understand that the chances of having a baby from IVF, the chance is still very much dependent on the age of the eggs that we get. So you can see in the bar graph on the right that eggs that come from ovaries of an individual who is under or younger than 35, they all have very similar high rates of live births per embryo transfer and per IVF cycle, but this declines with age. So the likelihood of success with IVF still very much depends on the likelihood of creating a healthy embryo, and age is the best predictor of this. Okay, so here's my slide talking more about PGTA, or the pre-implantation genetic testing for aneuploidy. Aneuploidy just means having an incorrect number of chromosomes. So this is what we use to determine whether embryos that we believe look normal in the lab are actually healthy embryos, right? When we just look under a microscope, we don't know if there are genetic abnormalities within an embryo. But thankfully, we now have this technology to be able to screen them. And you can see over the past decade, the percentage of IVF cycles that are utilizing PGTA has increased significantly from about 5% to 50%. So as I mentioned before, PGTA would require that we take a biopsy from each embryo that we believe developed normally. The biopsy then gets sent out to analyze the chromosomes. And when the analysis suggests that the number of chromosomes within that embryo is normal, that single embryo gives about a 60% chance of pregnancy and lowers risk of miscarriage to about 10%. If you look at the graph on the right, it shows that when embryos are screened for chromosomal abnormalities, normal embryos, regardless of the age of the individual whose eggs were used, normal embryos give similar high odds of success. So I think the important message from this is that the challenge with age and IVF is not getting pregnant with a normal embryo, but creating a healthy embryo. And with age, there will be a lower percentage of healthy eggs, a lower percentage of healthy embryos. And as individuals get older and are thinking about doing IVF with their own eggs, it's not uncommon, in their late 30s or early 40s, it may take more than one round of IVF to find a healthy embryo. All right, so I just want to touch upon the doing IVF with donor eggs in which then the created embryo can be used with a gestational carrier, right? So gay male couples, or couples who are unable to provide eggs and the necessary uterine environment for pregnancy, can still achieve a biological child by using IVF with donor eggs to create the embryos, and then having a gestational carrier carry that pregnancy. This type of treatment was not an option in New York until 2021, when the Child Parent Security Act was passed. This law legalized gestational surrogacy and provided a simpler path to establish legal parental rights for parents who rely on this assisted reproductive technology to have children. And in addition to expanding protections for LGBTQ plus families in New York, the law makes it easier for intended parents to work with paid gestational carriers in New York rather than having to go out of state, which is what we used to do. I will tell you that over the last couple of years in New York, right, because of this law, the number of IVF cycles that we are doing this way for gay male couples has increased dramatically. And these types of cycles tend to have very good success rates. There was a large study done in the US that suggested that this type of treatment can give close to an 80 to 85% chance of having a baby. That doesn't mean each embryo gives that chance, but overall with the whole treatment cycle, extremely high odds of having a single successful pregnancy. In my experience, I will tell you that most of my patients using this type of treatment are using anonymous egg donors, typically frozen eggs from a bank, but fresh egg donors can be used. And they are working with an agency to be matched with a suitable gestational carrier. Also, with this type of treatment, PGTA, the genetic testing of the embryos, is used in nearly all cases. I will tell you that finding a suitable egg donor and gestational carrier, it takes time. This is not a process that's going to get done quickly. At RMA, thankfully, we have a designated team. We call them our third-party team, who can help our patients throughout the whole process. We provide patients with information regarding the donor egg banks. We also have our own internal egg bank. Occasionally, when individuals want to use a fresh donor, we can help them with that. Of course, we help with finding agencies for gestational carriers. The gestational carrier agencies themselves help guide patients in, the initial choice of who might be a good match, but then the physician they're working with ultimately reviews all of the records and makes a decision. But the agency will assist in all of the legal aspects and the contracts that need to be in place. They do background screenings on these gestational carriers. And of course, before they even get brought to my attention, we make sure they meet all of the necessary criteria medically to be a gestational carrier. With this type of treatment, it is also possible, right? We're going to be using, if this is the type of treatment typically used by a gay male couple, we can use the sperm from both partners to fertilize the eggs. Typically, what would happen is of all of the eggs that we get, either from the frozen egg from the bank or from a fresh cycle, we would split them. So half get fertilized with sperm from one partner, half get fertilized with sperm from the other partner, so that they can both have embryos that are genetically theirs. So it's a really nice treatment, and it's really great that the laws have changed in New York. I just want to briefly touch upon fertility preservation options. So essentially, the options for preserving one's fertility is either to freeze eggs, to freeze sperm, or to create and freeze embryos. Fertility preservation is an option for anybody who is not ready to have children, but knows or at least thinks they want the option to have their own biological children in the future. It is a treatment option also that should be considered for anybody who might be undergoing any type of hormonal treatment or surgical treatment that could impact their eggs or sperm. And finally, just a few take-home messages just to summarize. Essentially, there are multiple modalities of fertility treatment that members of the LGBTQ plus community can use to create their families. We need to ensure that members of this community are aware of their options. Third-party reproduction is typically necessary and does have additional FDA requirements to consider. IUI and IVF are the two big categories of treatment, that we can offer. And within IVF, there's also the option for the co-IVF or reciprocal IVF, as well as creating embryos using donor eggs through IVF. and then using a gestational carrier to carry the pregnancy. And then, of course, fertility preservation options are available for anybody who needs to use them. All right, well, I hope I didn't take up too much of your time. I hope this was useful information. I'm going to do my best to see if anybody submitted questions. I think there's one. You'll have to forgive me. Technology is not my forte. Do you recommend that trans men going on testosterone freeze their eggs beforehand? What is the likelihood of still being fertile while taking testosterone? Does top surgery impact it? So that is an excellent question. I do think that elevated levels of testosterone can impact the quality of eggs. I think it is wise to freeze eggs prior to starting that treatment. If someone has already started the treatment before, going through a process to extract eggs or whatnot, it still can be done. But I do think it's best to do it prior to starting the testosterone treatment. I hope that answers the question. Let's see if there's anything else. I don't know if anybody else has any questions. Oh, yes. Does skin removal post-weight loss impact fertility? How long? Okay, so this question is whether skin removal post-weight loss surgery can impact fertility, and how long after skin removal does it make sense to get pregnant? So the actual removal of excess skin after weight loss should not impact fertility. And I will tell you, in general, the weight loss itself has a lot of positive change hormonally that can be beneficial for eggs and sperm. But the actual surgery to remove or tighten up the skin should not have any negative impact on fertility. The second part of that question, sorry, I'm just bringing it up. How long after skin removal surgery does it make sense to get pregnant? That is a good question. Being pregnant itself is going to stretch out the skin. That's probably a better question for the plastic surgeon or whoever is doing the surgery. I will say for us, we do have certain time restrictions, like if you're having weight loss surgery, like a bypass or something, there is a certain time during that rapid weight loss period where we're going to recommend you not get pregnant. But the timing for when to get pregnant after tightening or removing excess skin is probably better answered by your plastic surgeon. Another question that popped up, how does your weight affect IUI or IVF success? So another good question. We know that being overweight, specifically being in that weight range that would categorize you as being obese, can have a negative impact hormonally, and that affects egg quality. We see that a lot. I wouldn't say it is the only factor. Rarely is it the only factor, but we know that when women are obese, that they tend to have higher rates of infertility. It can, especially if there's any concern about polycystic ovarian syndrome going along with it, it can make it more difficult for the ovaries to grow eggs and ovulate. We know that miscarriage rates are higher when obesity is present, and complications in pregnancy also are higher with obesity. But that being said, it's very difficult for me or for any fertility doctor to say that obesity alone in and of itself is an explanation for difficulties getting pregnant, but it can be a contributing factor. Okay, I think there's another question. Can a lesbian couple do IUI and both be biological parents, or is that only an option during IVF? So that would be an option only for IVF. with an IUI, for a lesbian couple with an IUI cycle using donor sperm, the partner who is going to have the IUI done, it's going to be that egg, right, the egg from her body that is going to ovulate, get exposed to sperm, and potentially fertilize to create the pregnancy. So with IUI treatment, the genetics of that child will be from the person who's pregnant, the partner who's pregnant, from their egg and from the donor sperm. IVF is the only way to allow both partners to kind of participate in the pregnancy and in the genetic creation of the embryo. One more question. Does GC age impact pregnancy success rates? So yes, in general, the quality of the egg is more important, but there is an upper age limit cutoff for gestational carriers because of potential for complication in pregnancy. So it's not so much a concern of them getting pregnant, but the slightly increased risk of having diabetes in pregnancy, high blood pressure in pregnancy, requiring a C-section, preterm delivery, placental abruption, all of that is higher as a woman's age increases. So there is an upper age cutoff. I want to say 41 is the cutoff, but I have to double check that. But yes, the age can affect the overall live birth success rate for a gestational carrier. Okay, so one more question that came up. Can we talk about the legal aspects of having a baby? What if our child wants to meet their father in the future? Is there any option for the sperm donor to be in a baby's life as they're growing up, or are those rights signed away during the legal process? So with donor sperm, that is going to be kind of legally set out in the paperwork that you sign with the sperm bank. So that's not so much something that we're legally taking care of. I think that there may be options for more of like an open donation where maybe the sperm donor allows you to contact them in the future, but I think it really has more to do with the options that are available through the sperm bank, because they are the ones taking care of kind of the legal contracts of you purchasing the donor sperm and conceiving with the donor sperm in the future. All right. I think I got all the questions. I want to thank you guys for joining me tonight. I hope this was some useful information. And I wish you the best of luck in your future endeavors and whatever you may be doing to have your family. All right. Have a good night.